5% mistake the umbilicus and incise lower or higher than the umbilicus. This is due to confusion over midline marks, thinking they are the umbilicus. How to avoid this mistake? Either mark the umbilicus with a surgical pen before draping, or, once draped, lift the drape to double check before you apply the towel clamps. "10% miss the linner alba by over a centimeter. 50% miss the linner alba by less than a centimeter. How to avoid this mistake? Cut more of the fat away until the white line can be clearly seen. Despite the dog appearing straight, realize there could be some rotation and the linner alba may not be midline. 1% cause serious damage to the spleen. 10th the linner alba higher for the stab incision. Make sure the scalpel blade is reversed. Raise the muscle more when extending with scissors. 20% go off midline when extending with scissors. Take time when extending. Keep checking the peritoneum. Try placing forceps and lifting the muscle, and keep the midline in the center of the forceps. 75% cannot find the uterus. 10% cause splenic damage with a spay hook. Initially avoid using spay hooks. Think more about the anatomical position of the uterus. Try finding the broad ligament fat and this will take you to the uterus. Best position to look is cranial to the bladder, as usually just uterus and colon here. When placing your index finger, pull the muscle towards you. This helps you get behind the abdominal contents. 10% pull too hard on the uterus, causing damage. 75% cannot break suspensory ligaments. Don't pull hard on the uterus to get to the ovary. Push down on the abdominal wall to get to the ovary. You can pull hard on the ovary, as this is protected by the renal and suspensory ligament. 10% break renal and suspensory ligaments, resulting in ovarian bleeds. 50% don't know there are two ligaments. 1% will break the ovarian vessel near its origin at the aorta, resulting in massive bleeding and death in some cases. This is due to poor technique. Do not strum it like a guitar string. Slide down as far as you possibly can and push down at, or near the insertion to the rib. They break in seconds with this technique. Trace the renal ligament. It runs to the kidney and the suspensory runs back, past the kidney. Only try to break when your finger is fully in. The more cranial you are, the safer you are. Using the technique in the videos will keep you safe. An incredible 25% damage the ovarian vessels when trying to make the window through the broad ligament. 15% of these will result in massive hemorrhaging. Take your time to choose correct location and do not rush it. Make the window in a translucent area where you can see no vessels. Do not go close to the ovarian vessels. 7% hold the vessels when placing the clamp, causing vascular damage and massive hemorrhaging. 40% have some of the ovary in the clamp, which will result in ovarian remnant syndrome. 20% get extra tissue caught in the clamp. Only hold the ovary while you are placing the clamp. Walk the clamp down a bit at a time, compressing the clamp, not clicking it. This allows you to remove anything caught, as long as you haven't broken the renal ligament. This protects you, so you can pull on the ovary to create more space. Lots of new grads have told me they never get told about the renal ligament, and some unis have actually told them to break the renal ligament. It is very unlikely you have seen this technique, but times are slowly changing. The triple clamp technique has been taught for probably 100 years, and nobody has tried to simplify the technique. So after performing 2,000 bitch spays a year and helping new grads for 10 years, I set about simplifying the technique, and that is what you will see in the videos. When students made repetitive errors, I changed the technique around this. So this is the first trick which helps: uterine separation. Place the clamps behind the uterus and clamp twice, cutting between the clamps. This gives massively improved exposure, and ligament placement is more precise and a lot easier. There is no danger to it. Even if both clamps fell off, you can just pick up the ovary. On a risk versus benefits, benefits far outweigh. 15% of new graduates had no idea what a Miller knot was. 60% couldn't form a Miller's but had some idea. If you are spaying a large obese dog and not using Miller's, the risk of serious bleeding vastly increases. One new graduate thought you made a Miller's and no singles came after it. 45% formed the Miller's flush to the clamp and didn't understand that a knot so close to a clamp will not tighten. 60% formed Miller knots so loose that there would be bleeding. 20% formed them so loose they would fall off, resulting in massive life-threatening hemorrhaging. Focus on getting the Miller's as tight as possible and then check it 2 to 3 times if it cannot go any tighter. Follow the knot with 5 to 6 ones. Ensure the first 3 are tight. Avoid cheaper PGA, as knots can open up. Watch the videos on how to nudge the knot down into a position it can tighten easily and leave much space for the second Miller's. 5% will rip the ovary off while tightening the Miller's, resulting in life-threatening bleeders. Do not pull upwards on the tissue while ligating. Work down to the tissue. So, you are not putting pressure on the pedicle. Don't work far out. Your hand needs to be near the knot. So, if there is a slippage or the suture breaks, the tug on the ovarian pedicle will be less. You can see the technique for Miller knot positioning. Initially keep it loose, then nudge it down with blunt forceps. You can see the effort in making sure these are tight ligatures. You have to make this effort and not just place the throws, otherwise hemorrhaging will occur. Only 10% or less place the ovarian clamp low enough so that it could be raised for the second Miller knot. Most had to place the second ligation without any extra tissue. If this occurs, you are best placing the first Miller's, and then with the second, place it so the tails go the opposite way. The simplest way to get the knot opposite is walk round the table and place AM Illers as usual, and hence the knot is opposite. After the first Miller knot has been formed, the ovary is held and the clamp raised. It is essential that there is palpable clearance of the ovary. The Miller knot is placed below the clamp and initially kept loose. Nudge it down at the back of the clamp and the front, so when it bites it will be lower down. 1. Wrap the suture around the pedicle and drape it over your index finger. To pass the suture over the index, making a cross and hold with thumb. 3. Then wrap suture around pedicle and make a second identical cross over the index and hold with thumb. For now, send your needle holders through the loops where your index finger is and grop the tail. Five. Now pull the tail through the loops and then back in the direction it was. Keep the Miller knot loose, nudge down at front and back, and then tighten in position. Ensure super tight and follow with 5 to 6 ones. If you ever wanted to add a third knot, keep hold of the tails of the miller knot. So the next knot will slide beside it and the tails will not get caught. Place the suture, rotate and tighten, then add the singles. "100% checked for any ovarian bleeding, in a dangerous and difficult way. They cut the ovary off and try and hold onto the pedicle to check for bleeding. This way can make it super difficult to pull up the pedicle and replace a clamp. Most of them are hanging onto it by a thread and others are destroying tissue. So much so the last ligature may slip off. With the uterine separation technique, checking for a bleeder is super safe. You release both clamps and just hold the bursa, and in some cases you can just let go. Don't attempt T6 letting go if you didn't break the suspensory ligament. Reapplying the clamp is easy and once happy no bleeders. There is no need of that risky hanging onto the pedicle by a thread. "15% damage the uterine vessel when making the window in the broad ligament to then clamp and ligate. All they need to do is stay away from the vessels. Stay at least 0.5 centimeters away. Try and make the window further down, near the body if possible. The vessel goes closer to the uterus the further you go down, and then eventually is side to side of the uterine body. Just be careful and aware. 10% break the broad ligament clean off, whilst ligating. Work down at the level of the knot. Most don't realize, but as they are ligating, they are pulling up on the tissue, and as it is fragile, it breaks easily. "5% vets have told me previously they have got to this stage and realized they have mistaken a lymph node for an ovary and intestine for uterus. They have removed them and only once getting to a non-existent bifurcation have realized their error." An experienced colleague of mine, of 15 years, removed the kidney and ureter, thinking it was the ovary and uterus. "50% cannot find the other side of the uterus, unless it is very easy like this one. 5% have mistaken intestine to be uterus. 25% cause a large amount of serous fluid from their digging to find the uterus. Put some light tension on the uterine horn you have. This will bring the bifurcation closer. Imagine where the uterine horn should branch off and follow it halfway along before trying to pull it up. Remember, it is anchored at the bifurcation and the ovary. Check on the opposite side, as the uterus can sometimes twist. If it is a continence problem, make your skin incision lower. But the downside of this is that it will make the ovaries tighter. Feel as many uteruses as you can, if your colleague is operating, as them if you can have a quick feel. So, rather than pulling on the uterus and risk it snapping, we push down on the body wall so we can grasp the ovary. As already stated, you can safely pull quite a lot on the ovary as ligaments protect it. With this side, the suspensory is nearly twice as thick. Try pushing down at the insertion first. If not working, try a lateral force and try and break it in too. If not, place your finger to the lateral side and try pushing it up. While doing all of the above, you need to be as deep as possible and keep some tension on the ovary so the ligaments are taut. But don't break the renal, just the suspensory. Make the broad ligament window clear of the vessels. In a trace, and sluice an area as far down as is comfortable. Place the clamp through the window and while holding the ovary. Walk the clamp down and hold, but don't click. Remove any fat tissue or nipple. Walk down again until it is as far as you can get and then click the clamp. Now place 2 clamps above the ovary. They must go through the same window as did the ovarian clamp. Cut between the clamps and thus separate the uterus. Form the miller's knot below the clamp. Don't tighten. Let it stay loose. Place the suture over your left index finger and hold it with your thumb. Now place the other end of the suture material over your index finger, making a cross with the other suture material. Place your thumb over the cross and hold it. Take the suture around the pedicle and then make a second identical cross over your index finger and hold in place with your thumb. Now with your needle holders, go through both loops where your index finger is. Grab the end of the suture, pull it back through the loops, and then place it in the direction it was originally. Now with this loose miller's knot, we nudge it down at the back, and then down at the front. If you can rotate the clamp, this will help you to tighten the millers in its lowered position. I often use forceps in the handle of the ovarian clamp to achieve this. I tighten the millers as tight as I can, checking it 2 or 3 times that I can't get it tighter. Holding the ovary, the ovarian clamp is raised. Ensure none of the ovary is caught in the clamp. A second millers is placed. Again, the knot is nudged down, so it will bite better in a lower position. I place an extra knot, a surgeon's knot, just to be 100% sure and to demonstrate. The most important tightener is the first one through, as this tightens the surgeons. If I ever do this, I place the tails to the opposite side to the millers. So the separation technique allows us to check for bleeders in a very stable environment. Now we just remove the clamps, including the ovarian pedicle, and you can see there is no bleeding. We replace the clamp and remove the ovary and then just release the clamp. Make the window away from the vessels, through a translucent area, as deep as possible, but not too close to the uterine and vessels. As the broad ligament looks vascular, a millers was placed. "30% of students place a loose surgeon's knot. A surgeon's knot is placed first as they are least likely to cut through the uterus. Next, we place a millers. 1% of new graduates, the millers will cheese wire, cutting through the uterus. 20% will place a loose miller's knot. 35% will place one with the loops separated at the back. Learn to recognize fragile uteruses, and in these cases, opt for catgut, where you can control tightness better, or select a thicker suture material, or go at 70% strength. Focus on your tightening technique here. Use more a push and pull with the suture, rather than a lateral force. Before tightening the milers, pull the suture a little vertical. This will bring the loops together. Or rotate to the back of the uterus and nudge the loops together. A second Miller's was placed. 30% find it difficult to close the uterus with transfixing ligatures, mainly because each one is tied as a surgeon's. I have less uterine hemorrhages if the new graduates use to Miller's, as they at least tend to get at least one Miller's tight. When the uterus is cut and checked for bleeding, initially check it in the position it is, then nudge it into the abdomen and check again. This is because in the past, there has been no bleeding initially, as the vessel is trapped over the muscle, but once released, bleeding started. For abdominal closure, 10% of new graduates make muscle sutures to loose. 20% make them to tight, so much so, blood supply was restricted. 15% do not get a good enough bite of the muscle. They are taught to take small bites. But this would only be applicable if the entry was perfectly through the linea alba, which never really happens. Larger bites of muscle would be safer. 35% who do simple continence place the suture too far apart, sometimes resulting in herniation. 40% do their simple interrupted with too much spacing. 35% put the sutures too far apart. Closer in rescue dogs has to be perfect, as they receive no post-op confinement and are usually bouncing up and down once back in their cages. To overcome these errors, spend a little more time and effort with the closing of the muscle and don't rush this part. Pre-COVID, many students were allowed to close abdominal surgery on EMS. Post-COVID, far fewer are allowed to do this, and there has been a very noticeable decrease in competence with closing. If the muscle incision under runs past the skin incision, then it is worth put an interrupted at the top and bottom first, while access is at its best. A scary 5 to 8% of students close the fat, thinking it is the muscle. To prevent this, then I encourage that after the skin incision, the fat is cut away, rather than blunt dissected. Cutting the fat usually makes muscle and fat layer more distinctive, reducing the confusion. Placing an Aberdeen halfway down makes the muscle closure more secure. – 30% or more don't think about hiding the knot in the fat. You can hide the knot by placing a simple ligation in the muscle. This then works as an anchor, and you can go straight into the fat closure. But if starting in the fat layer, place the suture deep superficial on one side of the fat. Then go superficial deep in the other, tie off. And then first pass has to be our deep superficial. Because I snip both ends of the fat, the intradermal layer should be started with a subdermal anchor as shown. Now head towards the end of the incision, coming out at the intradermal position, and the knot should lie horizontally and be easy to cover. I tend to hold the needle closer to the tip than shown at uni. I feel it gives you better control, increased strength, and it allows you to take more bites as you go along, making the pattern stronger. 80% of new graduates tend to do acceptable intradermals. However, 20% just cannot do them and want to use copious amounts of skin glue. A staggering 90% cannot bury the knot properly, and often leave it sat in the skin apposition. This means in 3 weeks when the suture breaks down, there is a hole in the skin, which often leads to wound breakdown. Try to leave a small hole at the end for burial. Do not try and bury the knot a distance from the base of the knot. As this would be impossible, bury close to the knot base. If an Aberdeen isn't working, try a surgeon's. If the knot glides through, the knot should bury easy. If the knot is not gliding through, go again. If the knot doesn't bury, pull it back out and go again. Just take note of this knot I have formed. I nickname this a hybrid knot. I started with an Aberdeen knot, which went wrong. So I continued like a surgeon's knot. So it didn't fall to pieces and salvage the situation. To prevent snapage, pull gently on suture and use rat tooth to push skin over the knot. If using an Aberdeen, pass through twice at the end to reduce knot unravelment. Useful tips to help you. If you have post-operative bleeding, the blood can be coming from one of two places. From the fat or skin. With this you tend to find the blood coming out is clotting normally. Internal from an ovarian or uterine ligation. With this the blood that comes out tends not to clot. Also, if you go into a post-op spay, it will always scare you when you see the amount of blood in the abdomen. Usually the abdomen is completely full. This needs to be removed with suction and swabbing. But first put your hand in and go to each kidney area and uterine stump. Wherever you find the jelly clot, this pinpoints exactly where the bleed is coming from. One of the charities had for new veterinary graduates volunteering to perform neuters for them. They operated on 10 dogs, but had no experienced vet present to guide them, and sadly only 6 of these dogs survived. Investing time and effort in new graduates is essential and will be rewarding, as they tend to make quick learners. But it is not recommended to let them lose on their own. Those days have gone.